I just take a second sometimes to upload the PowerPoint, especially if the internet is acting a little slow. This PowerPoint is just an introduction to childbearing family. Talks a little bit about what maternity nursing is and some of the scopes and standards of family-centered nursing. We talked already a little bit in class what maternity nursing is, and we talked about how maternity nursing is a whole scope of different types of nursing. A lot of people come in thinking it's just labor and delivery, delivering babies, but maternity nursing includes prenatal and preconception care. It includes childbirth education classes. It includes not only prenatal care, but antepartum. Sometimes people have problems and are in the hospital and need hospitalization due to premature labor or high blood pressure. So that would be antepartum. And intrapartum is labor and delivery, where you actually have, you give birth to the babies, and that's kind of a fun place to work. There's lots of activity, and there's a lot of excitement there, but it can also be a very sad place at times too. And not only are we taking care of patients delivering, but when we think about it, 31% of our population have C-sections. And so not only do we have to know how to take care of the laboring patient, but we also have to be able to pre-op our patients, to be able to work in the operating room, and also PACU as we take care of them as they recover. So for those of you who are interested in either the PACU or surgical nursing, we get a little bit of that. Unfortunately, with our C-section rate so high, almost 1 out of 4 of our patients end up in the C-section rooms. We're trying to decrease those numbers going forward. It's huge initiatives to decrease the amount of people getting their first C-section, which would include decreasing the rate of C-sections in general, because once a person has a C-section, their chances of having another one increase dramatically. We also have different other areas of nursing, including postpartum, and in the postpartum, there's a lot of teaching. You get to take care of the babies. In the delivery room, you also do newborn assessments on babies. You give babies medication. So there's a lot of different types of nursing. If you like ER, we have OB triage, which is any pregnant women. It's kind of like the ER for them. I've had people come in with scorpion bites, to motor vehicle accidents, to fractures, all kinds of stuff. A lot of times we work interprofessionally with the ERs and the ICUs, when sometimes we need to transfer our patients, but we always need to check mom and baby to make sure baby's doing okay. So maternity nursing covers a lot of different areas of nursing. A lot of people think that they're going to come in from med-surg and not use some of their med-surg skills, but just think about the whole population in general. We have a population of people that suffer from obesity, high blood pressure, diabetes, lupus, asthma, and all these patients then become pregnant, and now we have those conditions kind of like on steroids. So we still have the patients who come in with previous illness, and we take care of them. But when we talk about maternity nursing, we're basically talking about care during antepartum, labor, birth, recovery, and NICU. And antepartum is before birth, labor, birth, recovery. We also, under WIS, which is Women Infant Services, it includes the NICU, so that's part of our services as well. We provide lots of education on labor, birth, parenting, breastfeeding, just to have better outcomes and improve patient experience. So we take care of our patients throughout all stages of pregnancy, childbirth, and the first few weeks after birth. It is definitely life-changing. If you ask most women what my age, as they age, that you ask them, what were the most important events in your life looking back? And I would say most people would say it's either their childbirth experience or their wedding. And if you think about it, their wedding day, with only 50% of marriages ending in divorce, and also that people aren't getting married, you can see most people's most special event in life, as a woman, even as a man, is the birth of their child or their childbirth experience. And so we know it's a life-changing event. We know it's a very special moment for our patients. And so when our patients come into the hospital, a lot of times it is their first experience with the hospital. So they have a lot of anxiety and a lot of fears. And so it's really important to make sure that they understand we're on their side when they come in. We, we're excited. Is this your first baby? When is your baby? Is your baby going to be a boy or a girl? Do you have a name picked out? Because we want them to know that we're on their side. We ask them what their birth plan is. We tell them we're going to do the best we can to make sure they have the birth experience they want. We put their birth plan maybe in the chart. We put it on the whiteboard in the room. And we always say that, this is baby's first birthday. We're going to just coordinate. We want to, the plan of how they, want to celebrate that birthday is theirs. But we also let them know that, we all want good outcomes. And the only time that maybe we might intercede in that is that for safety, because safety always comes first. So on the whiteboard, I always put the goal of the day is healthy baby, healthy mom. Because a lot of people come in, maybe they want a birth without any pain meds, then they end up getting an epidural or a C-section, and they're kind of disappointed. And I always point back to the original goal of the day, which was a healthy baby, healthy mom. So it's a life-changing experience. A lot of people will, who have children will let you know that once you have a children, your life has changed forever, and not in a bad way. It's just life-changing. We've made a lot of advances of maternity nursing. If you Google up, women in labor or delivering in the past, there's not too much literature or pictures on it. But here is a picture I did find. And if you notice that what's a little bit different about this picture versus today is that the woman is sitting up in a chair. She's surrounded by women. I don't know what's with all the clothes, but maybe it's because they don't have a heated area or whatever. But most deliveries were done at home. In previous times when they started having in the late 1800s and early 1900s, they started having them in hospitals. And sometimes those patients were at a higher risk for death because of infection. But we've come a long way since then. And to the right, you'll see what a typical labor and delivery room in a hospital, because most of our patients today have the medical model of delivery, which is in the hospitals. So there's a labor bed that actually functions. It comes apart to deliver. It has stirrups. It has all kinds of stuff. You'll see a newborn warmer in there, which actually can heat up to keep the baby warm. It also has all resuscitation equipment needed for the baby, and the room is also resuscitation equipment for the mom. So it has made a lot of changes. There's been a lot of advances. The death rates of moms is definitely down with the invention of antibiotics and life-saving protocols and procedures for hemorrhage. So we made a lot of advances. But sometimes one would beg to differ, when we look at the medical model, if we're kind of getting back to more of a home model, or including nursing midwives and letting the experience be the patients. If we look back in history, in 1847 was the first reported use of OB anesthesia. Prior to that, who knows what they used, whether it was herbal, pain medication, whether it was whiskey, who knows, but that was the first reported OB anesthesia. And we've made a lot of progress since then. There are some women that do not like to experience pain as they deliver. And we have options. We have pain medication that we can give through the IV. We have epidurals. We also actually have those that want to deliver without pain medication. We have lots of breathing, relaxation, and other non-pharmacological methods to deliver. But there are pain medications and epidurals available. We also have nitrous oxide available, all for to ease the pain of delivery. The first childbirth education class was started by the American Red Cross in 1908, which basically opened up the door to education. 1960s was birth control pills were introduced, and prior to then, there was large families, a lot of deliveries, and that opened up a whole new door for women. And it's interesting to look, and you think 1960 was so long ago, but really it's not that long ago. And I don't know if any of you ever watch, a lot of people will say, oh, I want to be a nurse or a doctor after watching like Grey's Anatomy. There's a PBS special called The Midwife. And that's a very interesting program because it talks a lot about how childbirth was in the 1950s and 60s and the progression that even in that decade that came along, including birth control and how, pain medication, and how women back then, they would deliver more at home, and then how they ended up in the hospital. So it tells a lot of history. Some of those programs actually are pretty good. We'll talk a lot about RhoGAM and rubella vaccination. It was in 1968, and a lot of you may not remember that. But prior to 1968, if a woman was pregnant and she had got rubella, that baby could end up stillborn or with deformities. So just having that rubella vaccination has improved our outcomes quite a bit. Yes. So you can take a look at some other things that have developed. Today, when we look at care provider choices, we have the obstetrician. That is the doctor who's specifically trained for labor and delivery and to meet the woman's needs as far as prenatal and preconception care. They're the ones that are most of the doctors that you'll see that will deliver. When I first started, I didn't know a woman doctor that I worked with, and now there's quite a few women OB doctors. There's family practitioner physicians, and you don't see a whole lot of them delivering in the big hospitals. There's malpractice is pretty high, so a lot of, if you look at doctors that are sued, some of the doctors that are most likely to get sued with the highest malpractice insurance are probably OBs and anesthesiologists, who we work with very closely in our practice. So where you will see family practice physicians is probably in the rural areas. Nurse midwives and certified midwives, a lot of times you'll just hear the midwife, but there is a difference. A nurse midwife is a nurse who then goes on to go to midwifery school and becomes a certified nurse midwife. In the state of Arizona, we don't have any midwifery schools, but a lot of them will go online and then go to like Frontier, and they go maybe to take a few, checkoffs over there, but most of it is done online, or they can actually have somebody that they follow in the city that they live in. So that's for a nurse midwife. A certified midwife is just somebody who wants to become a midwife, but is not a nurse, but takes the training to become a midwife. So you'll see both of those in the practices throughout the hospitals as well. Again, when I first started working, there was very few, and they weren't even delivering in the hospitals. They were more for the home births. And now you'll see them in the hospitals and having in groups of practices with physicians and such on their own. Doulas is just a support person that the doula will take a training to learn how to support versus breathing, relaxation, massage, aromatherapy, all those methods of support. And you can hire somebody as a support person. Evidence-based practice tells us the more support a laboring person has, the better their experience. As much as we like to think as nurses that we're their main support person, usually it's their partner who they come in to deliver the baby with. But they can hire somebody to offer that additional support for them if needed. Doulas, they do support care, but they don't do any clinical work. They don't do vital signs. They don't do any vaginal exams or anything. They're just a support person. I should just say but they are the support person. There's different types of settings where you can have a baby. You've got hospitals, you've got freestanding birth centers, and you've got home births available. I will say this is that if you have any high-risk conditions, you're more likely not going to find a doctor who will deliver you at home, or maybe not even at a birth center. They'll probably want you in a hospital if you have high-risk factors. Healthy People 2020 are just objectives, measurable objectives to improve patient outcomes. And there's several objectives, but I would like to point out some new objectives for Healthy People 2020 that have to do with our department. Postpartum, a lot of relapse of smoking among women who quit smoking with pregnancy. There's a lot of women who, once they become pregnant, will quit smoking to improve their outcomes on their newborns. But what's interesting is shortly after delivery, delivery, they'll go back to smoking. So I think it's a great objective to try to look at that and see. It's a hard job to stop smoking. And so they've already done that. So we want to make sure that we want some initiatives to make sure that if they have quit smoking, that they don't go back to smoking once that child is born. Of course, there's always initiatives to increase preconception and prenatal care, and also decrease preterm birth. And breastfeeding initiatives are huge because we know that breast milk is extremely, it's very, very, very good for the infant, and it has lifetime effects as far as decreasing obesity and decreasing respiratory infections on our infants, and actually decreasing obesity, all kinds of things. So we'll talk about that when we talk about breastfeeding, but we do encourage breastfeeding. We have huge initiatives in the hospital to support our women who choose to breastfeed. So we have some really good initiatives that we're working on. And again, they're measurable so that we can see if we're actually making an improvement on. When we look at maternal mortality, approximately 800 women die each day related to pregnancy or childbirth. And a high portion of these are preventable. And we know that improving access to services is huge, especially in third world countries like Africa. But worldwide, if we look at what harms our patients the most, we would have to say hemorrhage, infection, and eclampsia, or high blood pressure and hypertension conditions during pregnancy. And so because they have such a huge incidence and they contribute to maternal mortality, I can guarantee you we're going to be talking a lot about hemorrhage and some of the protocols to decrease the chances of bad outcomes regarding that. Infection, probably every week we'll talk about infection. And hypertensive disorders is huge in our department as well, which includes eclampsia. There's a lot of issues when we talk about women's health. We know that the two most reported medical risk factors in pregnancy is hypertension and diabetes. So we're working on how to improve our outcomes with those two medical risk factors, or decreasing, of course, the people coming into pregnancy with high blood pressure and diabetes when it is preventable. Teen pregnancy is an issue. They are teens that do get pregnant and deliver, have their own special needs, including a lot of times they need a lot of education. Their diet, they eat a lot of junk food. They tend to go towards that. So healthy eating, healthy habits need to be discussed. So there's a lot of education and support that needs to go to our teen pregnancies. Tobacco and electronic cigarette use is an issue that we see, as well as substance abuse. And we both know that they can have long-term effects on our outcomes and our infants. Obesity, 25% of women who were pregnant in 2014 were obese. That is totally preventable. So we're trying to work on some initiatives to decrease obesity in our society, but also to improve the outcomes of those women who come into our department obese as well. And of course, health disparities have been an issue for years, and they continue, and we continue to work to decrease that as well. We have a lot of issues with the United States healthcare system, and a lot of you are aware of this and have talked about it in previous classes. There's always the high cost of healthcare. What we do know now, though, is that midwives do decrease those costs. There's always a problem of limited access to care, which includes transportation, childcare, Medicaid. I mean, there are times when we call up and ask a woman why she missed her prenatal appointments, and she said she didn't have anybody to watch her kids, and she didn't want to go to the office with 3 kids. And then again, transportation remains a huge problem sometimes as well. There's the healthcare reform. We have health literacy, infant mortality, again, health disparities, and just the structure of the healthcare delivery system that we're still working with to improve. And by improving those, we will improve our maternal and outcomes, and that's what we're always striving to do. We also know that some of the issues are medical errors in our system, and I'm sure in their first level you saw some probably videos or heard about, some of the errors that occur in the hospital. And in 2007, the Centers for Medicare and Medicaid actually issued rules that denies payment for 8 hospital-acquired conditions. And some of those are actually very pertinent to us in OB. A foreign object retained after surgery. 31%, as you heard, of our patients in the United States end up with a C-section, which is surgery. So we have initiated safe surgery, where we count all the labs, and there's lots of things that we do to make sure that our patients are safe in surgery. But it's not always the foreign object that's left in a C-section. If you have a vaginal delivery, sometimes there's a little laceration or something maybe on the cervix, and the physician or midwife may put a 4x4 to stop the bleeding so that they can see, and sometimes that's accidentally left in there. Then they come back a couple of weeks later with foul odor from the vaginal area, and they found out that there's a 4x4 or something left in there. So even for deliveries, vaginal deliveries, you'll notice us that we'll do counting all the laps or the 4x4s and the instruments on the table prior to delivery. To increase our to have optimal outcomes. Blood incompatibility, we talked about hemorrhage is a huge factor for maternal mortality until it's the end of the day, and I've already talked quite a bit. So I'm kind of fumbling on my words. Blood incompatibility. So we have the problem of hemorrhage. We know that women die from it. And it's interesting how big of a problem it is worldwide, and we know that women can die from hemorrhage. And I've seen a lot of women hemorrhage, but I've never had a patient that I've actually seen die from a hemorrhage, because we have such good protocols. But we also give a lot of blood, because when a woman hemorrhages, they can hemorrhage and they can go hypovolemic really quick. So we do give a lot of blood in our department, and we got to make sure that we do it correctly. Falls and trauma, pregnant women lose their balance. We have epidurals, we have spinals, we have C-section patients. So we have to be very careful with our fall precautions. And when we talk about catheter-associated UTIs, there's lots of catheters that we place in our department. A good portion of our patients, at least 75% in some hospitals, will get epidurals, and most of those patients with epidurals will be cathed. And also our C-section patients end up getting a Foley catheter. So we have huge initiatives to decrease the amount of UTIs with our initiatives on getting the catheter out as soon as possible, and those types of things, which we'll talk about throughout the course. On a global perspective, the world does become smaller with travel and technology. We have the Zika virus that is kind of new. We're still learning more on that. We have female mutilation or circumcision. A lot of women, like Somalia, they come. We had a lady once that we had to do a C-section on, and because of her female circumcision, we couldn't actually get the Foley in. We actually had to call a urologist to place it. Human trafficking is another global issue that we're dealing with currently today. There's recent trends that we're seeing in our department. We are increasing preconception and prenatal care. The difference between that is preconception is going into a pregnancy healthy, meaning making sure you're on prenatal vitamins, making sure that you're if you're coming in with any health problems, you've got them managed, like your diabetes. It's making sure that, if you smoke, you try to quit smoking, to make sure you're not on any medications that can harm Ha's to the infant, including illicit drugs. We have childbirth education classes offered in hospitals and outside of hospitals, and quite a variety on that. Now, of course, I do teach childbirth education, and now they're going virtual. We're trying to decrease. We're trying to decrease our initial C-section rates, but we're also when we had such a high incidence of C-sections when I first started nursing. A lot of times they were saying once a C-section, always a C-section, and then they said no, we can do vaginal births after C-sections, which is what a VBAC is. So for a while there, we were increasing our VBACs, but we had some problems with with some bad outcomes. And so now there's been a little bit of a decrease in the VBACs, and we want to make sure, that we continue to do them safely. But also, if we decrease the amount of C-sections, we can hopefully decrease the amount of VBACs that are needed. There is an increase in cesarean births. Some say up to 32.9%. The last record that I heard, in some places, it depends what hospital, what state, but they range anywhere close to around 30%. We're seeing an increase in nurse midwives and doulas. We're seeing some trends in fertility and birth rate. So it's interesting. A lot of women are waiting to be past 35 and then having problems with getting pregnant. We're seeing less people, we're seeing less actually, the birth rate is actually dropping because people are wanting less children today as well. We're having a more family-focused childbirth, and we allow alternatives in care. We have a lot of water therapy, aromatherapy, acupressure, all kinds of things that we use for pain relief. So we integrate complementary and alternative therapies, which I'm really huge on. I'm an aromatherapist myself, and I've done a lot of classes on supporting patients during labor. There's a lot of ethical concerns that have increased. That's been with genetic testing. We do genetic testing. The problem is, what do we do with that information? We also have IVF. We have frozen embryos people don't know what to do with. We'll talk a little bit more on ethical concerns throughout the program, but particularly when we talk about genetics and some women's health issues towards the end. We're seeing patients coming in, and we want to get them out as soon as possible. Number one, hospitals, you can have hospital-acquired infection, and also to keep our beds open and for economic reasons. But usually on a vaginal delivery, we're trying to keep those stays about 24 hours. There's a lot that goes on in that 24 hours, a lot of education that is needed. A lot of C-sections at least will be there 2 nights, but a vaginal delivery would be a good 1 night and there, which usually ends up 2. It depends what time they deliver, but we're trying to get them in and out. And there's some good things about that, and then there's some difficulties and challenges that arise from that because of the education and making sure that they're ready to be a parent by the time they leave the hospital. There's always an emphasis on community-based care as well. We want to prevent errors. We have a lot of, whenever there's a centennial event, like, in our department, we do have babies that are born stillbirth, or they die, or they have bad outcomes. And what we have in our department is those can be very, very traumatic. I can tell you that it's one thing when a baby dies, but if we lose a mom, it's very traumatic to the whole staff and everybody surrounding that patient. And it doesn't happen that often as far as moms. I've been in the practice a long time, and I've seen 3 moms die. But I still remember every little detail of that day. But whenever there is an event like that, we always do a debriefing to make sure everybody's okay. And for those that need additional help, we get them that. But I can tell you that it takes a huge toll on staff when those events do occur. Failure to rescue, we want to be able to note when a patient is going downhill and to get them the help that they need. We have a lot of protocols on that. We have, we can call for help as the patient is declining, whether it's blood pressure, bleeding, seizure activity, or whatever, to get them the care that they need. And then ethical issues, which we already talked about, legal issues. We work in an area that there's a lot of legal issues, and so that's where charting and making sure that you follow policies and procedures come in effect. I always say this, is that as a nurse, as long as you follow the policies and procedures of the hospital, they will protect you, and you will protect yourself, and that includes good documentation. What is a family? Basically, a family is whoever they say they are. Before we used to have, the family, what we used to see, we used to say, oh, there's the mother and the father and their kids, but now it's whoever they see. We have single dads, we have single parents, we have, 2 dads, we have 2 moms. We have, all kinds of different families. It is whoever they say they are. Just be careful when you have a patient come in. Whoever comes in to be their support system, we tell them, that they are their partner, and they can define them, whether it's, a spouse, a partner, brother, sister, whatever, but don't take anything for granted. Whoever comes in with them is their partner and their support system. There's a lot of family theories that go, we talk about it. I'm not going to get too much into that. Culture is a huge thing. It is throughout nursing. So we're going to talk, we have projects in clinical where you'll be doing a culture presentation and sharing it. They're very quite interesting to see how culture affects how patients manage their pain and some of their birth plan. And what's nice is knowing a little bit about that, and it helps us meet their needs culturally. And their spiritual beliefs and everything else. And again, home care in the community is growing, and that's community-based nursing as well. This whole maternity nursing brings up a whole new terminology. It's like a whole new language. So you'll get used to it by the end of the 5 weeks. The vaginal exam, we'll talk about that. You'll actually get to do some with my vag box in the simulation setting. Antepartum is just before they go into labor and delivery. Intrapartum is labor and delivery. Postpartum is after they deliver, which is sometimes referred to as couplet care. ROM, rupture of membrane. SROM, spontaneous rupture of membranes. And AROM is artificial rupture of membranes, when the physician actually breaks the bag of water. And we'll talk more about these in other lectures and also in class and when you go into your simulation time. GTPAL is basically when a patient comes in their prenatal history, you'll see it. You'll see it in the charting system. But basically, it gives us a little bit of a nutshell of a little bit of history on the mom. G stands for gravity, or how many pregnancies they have. If this is their first pregnancy and they've had no miscarriage or any other pregnancies, they would be a gravida 1. Okay. T is how many term births have they had in the past. So maybe they're a gravida 2 and they had a baby. Was it a term birth or was it premature birth? A term birth is 37 weeks and above. If it's before 37 weeks and greater than 20 weeks, we call it a preterm birth. So a preterm is anywhere between 20 and 37 weeks gestation. And anything under 20 is considered abortion. And when we're talking about abortion on GTPAL, you know how when you're charting and you click abortion and you'll say maybe 3, then it'll give you more, like what were those abortions? Was it a elective abortion? Was it a miscarriage? Was it a ectopic pregnancy? So but basically it's a loss prior to 20 weeks when we talk about an abortion. And then L is just for living children. And so I'll probably talk a little bit more about this on another PowerPoint. I will also go over it again when we do our simulation. And I may give you some, samples for you to do. And I think in some of your quizzes that you're going to be doing for Walters Kluwer, they will include GTPAL. You'll also do those for your SBARs in your BSIMs. So when SBAR is basically how do we communicate from staff to staff. I'm going off shift, and so an SBAR kind of guides me in that. And so this is kind of like an SBAR that we would use in the hospital setting, where it asks the patient initials, the age. I would say any age greater than 35 is considered advanced maternal age, which increase their risks. And of course, teenagers under 18 is a teen pregnancy that we take. They may need more education and a little bit more support. Gravida is what pregnancy is this. And para is basically how many births after 20 weeks. So if you're a gravida 1, para 0, which we also call primip in the hospital, but if you're a gravida 1, para 0, that means this is your first pregnancy you're coming in to deliver. Once you deliver, you'll be a gravida 1, para 1, as long as what you delivered was after 20 weeks. If you're a gravida 2, para 1, that means this is your second pregnancy and you've delivered a baby after 20 weeks. But that doesn't give us enough information, so that's why we have the GTPAL. Because what if you had a baby, if you're a gravida 2, para 1, and you think, oh, they have a baby at home, but maybe it wasn't. Maybe it was a miscarriage, or maybe the baby died in a motor vehicle accident. That's where you look at the GTPAL, which gives you more information on that history. Gestational age is just how many weeks pregnant they are. A normal pregnancy is 40 weeks. term is considered 37 to 40. After 40 weeks, you're post dates. So basically, the gestational age we would put there to kind of see where they are, because it alerts us to high risk. If they're less than 37 weeks, the babies might have a little bit more difficulty breathing and eating because it may be a little premature. In addition to that is the EDC, which is the estimated date of confinement or due date. So maybe the due date is September 1st, or what if the due date is August 20th? That would be today. The gestational age would be 40 weeks. Why did they come for admission? Was it high blood pressure? Was it bleeding? Or was it they were in labor? Again, their language, allergies, any reactions to it, events leading to admission. The bag of water broke 3 hours ago, started contracting. That would maybe be the event. Any risk or complications. It could be maybe their group made a strep positive. And then anybody who's had prenatal care, we will have already had their prenatal record at hand, hopefully, which would give us their blood type, their antibody screen, which we'll talk a little bit more about when we talk about Rh negative patients, and whether they're rubella immune or not. RPR is just basically if they're positive or negative for syphilis. We test them for all STIs during their pregnancy, but because syphilis is on the rise, we also check it when they come into the hospital, but it's really important to see if they're negative on that. Rubella, are they rubella immune? Meaning, are they immune to German measles? Most people are because they get the vaccination, but there's a few people that haven't. And if that is that they're non-immune, prior to them going home, discharge after they deliver, they will be given a rubella shot. The reason we can't give it during pregnancy because it is a live virus, which might be harmful to the infant. HIV, are they positive or negative? We check all our women for diabetes, which we'll talk a little bit more about when we talk about diabetes and high-risk pregnancy. But we screen all our patients at about 26 weeks with the 1 hour glucola. If that came out abnormal, then we would do a 3 hour. If the 1 hour was within normal limits, we do not do the 3 hour, but every patient gets a 1 hour glucola. So you should never see not applicable in that area there, but not a 3 hour. If that 1 hour glucola was normal, you would not need the 3 hour. Hepatitis B, chlamydia, and their GBS status. These are kind of the labs that we're going to look at and we're going to record because they're pertinent to outcomes, good outcomes. Is she on any medications? Probably maybe prenatal vitamins, maybe iron, maybe high blood pressure medication, whatever you would put that there. And then when she delivers, you would put she delivered the time, what type of delivery, was it a vaginal, was it vacuum, forceps, cesarean, did she have an episiotomy or laceration? We'll talk more about those in another PowerPoint. What was the estimated blood loss? A normal blood loss for a normal batch delivery is 300 to 500 cc's, and for a C-section it could be up to 1,000. And so we would put the estimated blood loss, which would be recorded by the physician. And that just gives us an idea if we need to further, maybe get another H&H or if she's already bled out a little bit as well. Did she get an epidural? Did she use a spinal? Was there a general or local? Baby, what was the APGAR? What was the weight? Is she breast or bottle feeding? Does the baby need to go to NICU or couplet care? Transition is sometimes when the baby goes to the nursery because it needs to be watched or needs some tests done on it, and any complications that arise. So those are kinds of the information that we look at. As far as assessment goes, if you have a laboring patient, part of your assessment will also include a vaginal exam, contractions, if she's ruptured, vital signs, pain level, how's the IV going. Once she's delivered, it's a different type of assessment, which we label as bubble HE, and we'll talk about that in next week when we talk about postpartum, and then, of course, your recommendations. So that just kind of gives you an alert on the important things that you're reporting off and the important things that you're paying attention to when you look at that SBAR. So there you go. There's an introduction to maternity nursing. This is the first of many PowerPoints. And so that kind of gives you a general introduction and gets you excited about what lies ahead. So thank you and have a nice, well, for me, it's late at night, but have a nice night. Thank you.